at his place. And I invite Dr. Ajay Sharma, sir, Professor and Head of the Department, Surgical Gastroenterology, Mahatma Gandhi Institute of Medical Science, Jaipur. Joining us online will be Dr. Rebala Pradeep, Professor and Senior Consultant, Department of Surgical Gastroenterology, Asian Institute of Gastroenterology, and also with him, Dr. N. Murugapan, consultant gastroenterologist at Sastra Hospital, Bangalore. At the outset, I need to thank Mr. Kapoor and all the organizers over here for planning a nice theme-based fourth virtual festival and giving me a chance to moderate this session. Apologies to Dr. Anand, I think I have not included his name in this panelist. I welcome all my panelists, Dr. Yadav, Dr. Anand, Dr. Desai, Dr. Pradeep, and Dr. Rajendra, who are available online. Okay.
Ajay Sharma.
Dr. Ajay, sorry, Dr. Ajay. I'm sorry.
People will also start with calling the.
So, I just brief background for some students if around. That chronic pancreatitis is a chronic irreversible disease with morphological changes, inflammation and fibrosis, structural stones. They do due to the Tigaro hypothesis of the etiopathogenesis, where toxic metabolite and other as described criteria are important. There is a damage to outflow and early activation of the enzymes, autodilation, stimulation of pancreatic cell and fibrosis, which lead to most of the symptoms. The main presenting symptom is pain, and the treatment hovers around the pain. So all the complications would be related to pain. I need to put a disclaimer that as such, there are a lot of complications associated with chronic pancreatitis while you're operating. But it's an area of ease and well, she talked in terms of exact course of complication, except for something related to recurrence of pain, which you counsel your patients pre-operatively. The other presenting symptoms beyond pain would be the weight loss, diarrhea, vitamin deficiencies, frail thin-built patients, the common patient come across, and over the time, the damaged pancreas doesn't produce enough insulin, there will be diabetes. There may be symptoms related to gastric obstruction. There may be dehydrated in these patients, and they may be presenting with obstructive jaundice or symptoms of cancer and pancreatitis. Can we get the quality of is it okay the quality of voice? Not the primary cause of pain is usually duct obstruction, hypertension, active inflammation over there leading to pain, tissue ischemia, and altered nociception. The secondary cause will be related to urine pressure symptoms, which you need to decompress, stricture, and then visceral neuropathy due to diabetes and hyperalgesia due to chronic dependence of drugs. We usually measure the pain based on Isabecki's scoring system, which takes into consideration four base, basic parameters, and then you try to target the disease output based on these symptoms or intervene based on this score. It's usually diagnosed on ultrasound, CT, MRCT because they pick up the disease rate, type of 3 and 4 disease, but some early disease need endo ultrasound, which is an important role in diagnosis, where you can pick up little dilatation and cyst, hyperechoic ductal margins without dilatation to point towards symptoms are due to chronic pancreatitis. Majority of the time, the patients go untreated till when they come with presentation like this. Less number of time you have this kind of presentation, a small dilatation or a hyperechoic wall of the duct, and you are eager to diagnose it early. And this is the severity of the disease. Usually use Cambridge classification. And each is a baby of equally, as we discussed, acute pancreatitis is the baby of more of medical gastroenterologist, and so is the chronic pancreatitis. And the disease is usually surgery is indicated in a step of manner where you have pain and the therapist or the medical management fails. There's also an upcoming protocol of early surgery in these patients, and of course, there's surgery for complication. So this is most of the people take guidance from this kind of working formula, that initially you try to control pain with medical management, endotherapy fails, or just small duct disease, and the pain is severe, you need to have an upfront surgery. So coming to the surgical target, when we operate on the patient, we think about giving a better pain relief, preserving good amount of endocrine and exocrine function, rehabilitation of the patient so that he has a better quality of life. And surgically, when we come across the procedures, we have major description of three kinds of drainage: the resection and the combined procedure where you combine resection with drainage. So, luckily, chronic pancreatitis is an area where you don't have much of complications post-operatively. Very rarely you may have a post-operative bleed, but most commonly the problems come across once you're operating on the patient. So you take a call between all these procedures based on your resection procedures, the drainage procedures, partition blocking is the one we do commonly. The combination procedure, the phrase is being done more frequently by many centers, then the Vegas, the Burmese, and then you can do a total pancreatectomy or distal pancreatectomy. So coming straight to discussion of what all problem do we have intraoperatively. We'll take it to case capsule. This is a young female who is 30-year-old. She presents with you with jaundice. She has a long history of pain, which is not that specific, but she has pain and it has been treated over the counter with PPIs and all, and she did not find much relief in that. She has history of some amount of analgesia. C19-9 is normal. There's no family history. So her picture is like this. She has a dilated biliary tract as well as she has a dilated tract with filling defect. So what would be your protocol? I would put it to Dr. Yadav. Would you tailor the procedure as the patient merits, or you think that one best operation for all, as I hear in most of the conferences, is that grace is a better answer to most of the questions? And if you are a proponent of praise in this particular patient, and if you don't want to add another drainage to the tract, then what usual problems or surgical risks you have while doing praise, so that we tackle with the intraoperative issues while doing praise?
So, if you see, there are two problems. One is this picture in the common bladder, lower down, and secondly, dilated pancreatic bed. So, I'm not sure how symptomatic is the chronic pancreatitis. So, if a patient has medical therapy, obviously there is no history of jaundice. So, only non-eccric picture is there, which is sometimes a very small.
No, this is an eccric picture. She presented with jaundice.
It's presented with jaundice, okay. So it presented with jaundice and there is a pain also. So little bit of tricky this situation is that some people would say that let's have drain the pancreatic common bile duct and wait for to see that whether the pain is the pancreatic duct is also same type of pain it is producing, or the pain is classical pancreas pain. If pain, we are sure that pain is because of the chronic pancreatitis, then I think the best procedure would be normally, I normally don't do LPG now since the beginning, and I will tell why. And then, since there is jaundice in the preoperative period, this patient usually pouring will not be very effective, not take care of jaundice. So we have to pour the head and do this drainage of the gut. Simultaneously, we have to do some lateral cholecystectomy also. I am doing cholecystectomy. Why I am saying, because once there is a jaundice beginning, only picture is a different scenario. Once there is a jaundice, it means this picture is very significant. And yeah, whether we should go do a drainage procedure like put a stent, then go for pancreas would be a little bit controversial decision. But in this patient, I would prefer doing
Okay, we agreed that you took an option of doing a double drainage procedure. Plus you would like to do a phrase for, because you do it for reasons. And I think I will not take a call of putting an ERCP drainage because she's not in cholangitis.
Yeah.
And
Terms of having some sort of
Duodenal obstruction.
issue. So it's better. It's very nicely take the same loop and take it to the gut area and it is about 10 to 15 centimeter away from the PJ. And nicely, in the same loop it can be drained. Unnecessarily opening another system like duodenum and lots of scarring sometimes present in the duodenum because of the continuous pancreatitis. So when I have to drain, I probably can go a little bit higher so that non-serous area in the gut as well as in the jejunum is nicely going and sitting there and take another extra 20 to 25 minutes.
And if this lady did not have any significant jaundice, but she had leaky grace, ALP, and mild picture, you would manage it with phrase. So, what would be your surgical complications which you can anticipate while doing phrase? And
So in
what
that
would be
case,
how would you tackle them?
Clinically there is a stricture, but there is no jaundice. Then we do a put a tube in the duct, cystic duct, and after plate procedure we push contrast and try to see whether it is freely moving. Because usually these small strictures which are not getting active, they will respond to this coring procedure. And the problem in the coring is one that there is a because you are coring the head, it is a blind thing. So you might have lots of bleeding, pancreas is such a vascular organ. So bleeding is the bipolar artery and use the bipolar artery to control the small spurters. If little bit bigger spurter there, we take some 4 or 5 PDS inside the duct and we take a suture. So that is the
Luckily, the timer is not telling us anything. It's staying at 60 minutes as of now, so you can add to it.
yeah.
You can continue.
Okay.
So he put up a very good point. And regarding if you take a lead from the cystic duct and you find a stricture over there, which is not a very serious kind of stricture, and phrase operation can tackle the stricture as well.
Small strictures which are not
A little
which
dense by
can
goes
be-
around,
yeah.
it takes simultaneously care of. So, anything else you would like to add?
So in the just beginning the distance you asked, so we know that we do a good cauterization. So left hand is lifting the pancreas up. So it's not in that the retroperitoneal, which is left hand is lifting. And we just where this gastroduodenal artery goes and bifurcates anterior posterior in that area, prophylactically we take a suture because it crosses, it becomes gastropancreatic artery and it crosses the pancreas through and through. So when you are coming from that to the head side, then there is lots of bleeding. So that is one thing precaution. Second is we take a suture about 5 to 6 millimeter away from the medial wall of the duodenum. Hemostatic suture. And they become a guide also when there is a bleeding. So we are not going more medially and injuring the duodenum. In the inferiorly, we are not going more toward the SMV and that is a guide also. And then you go bit a bit. Don't take it one go suture. Bit a bit suture slicing the pancreas and going depth and posterior wall of the duct is our limit.
So exactly what Dr. Yadav has put it very nicely that you have to tailor the procedure according to disease morphology and localization of the symptoms. There is a concept of, as he rightly said, that he prefers to do phrase procedure. In our series also, we take 60% of the patients are phrase, but it's not that we do away with pancreatic jejunectomy alone because we have some patients in whom LPJ is required. And it is always a must if you have a lot of head dominant disease and inflammatory mass over there where you are sure that's only inflammatory because it can move all stone strictures in the head area. And the trick, as he rightly said, is to do a safe procedure is to coat the head in bits instead of making a big bleeder over there. And you have to restrict your coding up to posterior duct wall. Some of the aggressive coding people actually go up to the posterior capsule of the pancreas. But once you go more deep inside, you have the risk of injuring the bile duct. So as it can take care of bile duct structure, so it can injury. You can find bile living surgery. It's a procedure which can have excessive bleed. And of course, you lose the last hope of treating surgically the patient of pancreatic cancer if you have not differentiated the mass appropriately. So you need to have an adequate mobilization. You disconnect the JSF fluid, You take away all of the mesocolon up to the duodenal base, the anterior head and the ulcer should be exposed well. You put your left hand behind after an aggressive cauterization, and you can buy time till when you suture the bleed. Usually, all of us who practice pancreatitis is just a pinch in between your back of hand and the thumb that you expose it nicely and give a suture, an accurate interrupt suture over there. You have to anticipate in a congested, inflamed pancreas bleed. And while pouring, it's appropriate, as you said, that you should take sutures all around the C loop by up to 5 millimeter margin. And in case it's still bleeding despite of those sutures, then you should, as you rightly said, that ligate the anterior superior branch of the pancreatic duodenal artery, or even sometimes you may have to do it with the GDA. So this is how a good coring can be done, and you should have a good control while operating. And these are the areas where you put the suture. To avoid bile duct injury, you should actually believe in doing a sharp dissection once you are coming to the area of a lot of cautery coagulation going. But if you want to release a stitch in particular and you want to go beyond the area where there's pancreatic portion of the bile duct, then you should use scissors over there. And then if there is a significant EHBO, then he said that you can take a guidance from CBD catheter, which was actually placed if there was cholangitis, so that you avoid injury. And if you see bile during surgery, you can just make the opening big instead of attempting to repair it, because you're going to create an occlusion. If there's a significant stricture, of course, he said that we add a second drainage, the hepaticogynostomy. And this opening, once made bigger, can be tucked around to the fibrotic pancreatic tissue, so that there's a free flow of bile. If you want to take phrase as your procedure to take away the stricture as well simultaneously, and then you can take it in the one group of pancreatic ostomy. Of course, phrase has shown outstanding results. Most of the studies claim to have pain control beyond 80% or around 80%. So this is another patient who's a young lady, 20 years old, significant chronic pancreatitis pain, no icterus, no complications, and a straightaway duct which is dilated. And you can see that no significant head over there for pouring. So I would like to take other panelists. Sir, is there Pradeep? Dr. Pradeep is there?
Pradeep is online. Pradeep and Murugapan are online.
So I think Dr. Pradeep can take this question, that what is your appropriate area of opening the duct if you want to do? Would you like to do an LPG first? I would like to know in this patient. I think he's not there.
List of participants दिखाएं.
Hello.
Hello?
Can you hear me?
Yes, sir, we can hear you.
Yeah, I couldn't get your question. Can you please repeat the question?
This is a young lady who's 20 years old and she has significant chronic pancreatitis with a dilated duct and strictures area at the neck. And she has no icterus and no other complications of chronic pancreatitis and no significant head mass or bulky head or disease in the head. So would you like to do an LPG in this? And what would be
I would like to, because young female and as of today, current guidelines, based on current guidelines, I would first offer a conservative medical management in this patient before I decide for
she has failed with conservative management. She has severe significant pain on and off, and putting her on analgesia protocol, the usual protocols we follow because we are focusing on surgical complication. She qualifies for a surgical procedure. For 6 months, she is almost taking an analgesic every second day. Though she has likelihood of failure post-procedure, and an important part would be counseling, she has a lot of drug dependence.
Okay, I can't see clearly the CT picture. Does it have multiple stone strictures? Because to what I could see, only the duct is grossly dilated.
Yeah, the duct is grossly dilated. She doesn't have multiple stones or strictures. So simply dilated duct with no add-ons like a distal disease, lot of stone in head. So would you do a Partington Lodge's LPJ? And
if the head is bulky,
yeah.
If the head is bulky, I'll go and do a coring. But if the head is not bulky, probably one can get away with. Sometimes you do an encounter that the head is not bulky, or even atrophied. In that case, a good drainage of the pancreatic ductal might be adequate in these
Okay.
patients if there is no inflammatory mass.
So where would you
But
exactly like to open the duct? Because you have the parenchyma is almost very little, and if you want to avoid injury to portal vein inevitably, and yes, the dilated duct with little parenchyma around. For the knowledge of the student, what would the safe way of opening the duct for LPJ? And how
yeah,
would
the easiest way, there are many ways to open the duct. The easiest way, if the pancreatic parenchyma is less, duct is dilated, you can just palpate, you can just feel the duct on the surface of the pancreas and put a needle, aspirate, and then open. It's much easier to open. The biggest challenge comes when you have a small duct and a big gland. That is where you will encounter problems. When there's a small duct and a dilated duct, it's much easier. If a stone is there, it again makes your life much more easier because you just bang on the duct stone, you can die. When you cannot find in a big pancreatic gland, small duct, I rather go start coring out the head of pancreas, and then you can get into the duct much more easily. From when I start coring, you will enter the duct.
Okay. So, Dr. Anand, Dr. Ajay, this is a straightforward case of, dilated duct with little structure in the head area, and she has got pain, and you have thin parenchyma. So, which is the best site to open the duct so that you have less complication?
Obviously, as Sarah said, you will find a duct, the uppermost portion in the pancreas. Even palpated with the stone, it becomes easy. Head coring is one method which everybody should know to identify the duct. When you core the head at the region of neck, you will find the duct opening, from which you can then extend the duct onto the lateral wall.
So, the ideal place to open the duct is
Beyond the neck.
beyond the neck.
Beyond
So
the
that you should go on to the left side of the
Yeah.
neck, and then once you are safe at opening it in between two sutures, then you take place multiple sutures because once an inflamed pancreas, we talk a lot of about bleeding during pouring of head, but we actually have bleeding even when you open up the duct in left pancreatic nostril. So usually we keep for technical ease pre-placed sutures. You hook them up, and if an area bleeds, once you cut it open, you tend to suture it and control the bleed at the cut edge.
For most of the beginners, you should understand that why it should be coring or beyond the neck. Because in the neck, there lies a portal vein just posterior to it. So in the attempt that if you injure a portal vein, there is no replacement for that other than dividing and then repairing the portal vein. So that area is non-retrievable. So you have to do either to the left of the neck or to the right of the neck, coring and then identifying the duct, or onto the left side of the body.
So palpable duct without coring can be opened up onto the left or to the right of the neck, and then you have to go beyond. So the important key point over here is that you have to keep in mind that you can injure your portal vein in a very thinned out pancreas with little parenchyma around, and you should be mindful about it. So now this is another patient who is 38-year-old male. He has pain abdomen, which is severe in nature. He doesn't have any jaundice. His CA19-9 is slightly elevated 67. He is diabetic. He also has symptoms of exocrine insufficiency. And this is his CT imaging. He has a mass in head of pancreas. And if you can see over here, and a dilated duct system. So you have few more cases where you have to take a call about malignancy in chronic pancreatitis, very important subject. Where would you like to take a call of pancreatic duodenectomy? Beyond management of pain, we all know that it has a role in management of pain also. So in this particular patient, would you give him an the benefit of doubt and go for Whipple's as I did in this patient, but histopathology did not show any malignancy. Many a times we know that's a straightforward case of CA head of pancreas with CCP. But in a tricky case with a mass like this, or a bigger mass like this with lot of necrotic area, very high CA19-9 1700, with almost most of the features suggestive that this is malignant. A loss of weight, appetite, but having a severe pain. So you have multiple cases where you come across a mass-like lesion. And this is another patient we operated upon. Is that again an inflammatory mass? So I would like to know from doctor. We'll discuss these cases later. Sometimes the patient may also present with GI bleed, which is recurrent, in upper GI endoscopy, it looks like Hemosuccus pancreaticus. This man is from a remote area who has recurrent bleed, and he has been managed conservatively with repeated upper GI endoscopy at a local hospital. Then he comes to us, and this is what we find on his CT angio. So, Dr. Desai, I would like to know from you that how exactly you take a call about taking a decision whether you want to go for an inflammatory mass associated with chronic pancreatitis or a malignant mass, and what procedure you should be doing. And sometimes if you go with an old imaging, you get surprised on table by seeing a mass, and you need to differentiate it whether it's inflammatory or malignant. And thirdly, I would like you to address that how challenging would be pancreatic duodenectomy, what would be the intra complications when you want to attempt it for chronic pancreatitis.
This is a difficult problem. Every pancreatic surgeon is going to come across this problem. Now, there are certain features in the history which should point you towards malignancy. One of them is significant weight loss, obstructive jaundice in an elderly individual with a bulky head of the pancreas. Here, and there is gastric outlet obstruction. These are late instances and they are of not much use to a surgeon if the patient has come to him early. When you face this problem of a bulky head, doubt of malignancy because he is elderly, weight loss is there, you want to think of how am I going to prove that this is a malignant mass. We have certain investigations that we normally do. One is the thing that we go to now is endosonography. Endosonography, we do plain endosonography, digital image analysis of the endoscopic ultrasonography. We do elastography of the pancreas using endosonogram, and we do contrast enhanced endosonogram. Now, with the first instance, where you do a normal CT, up to 2 centimeters masses can be easily identified by an endosonogram. Endosonogram nowadays also has a possibility of doing an endosono FNA or an endosono biopsy. You can do either an FNB or an FNA. FNA is less accurate, but if it is positive, it is 91% specific. The other thing is, if you get an FNB, people say, why don't you do a frozen section on table? It has been shown in carcinoma of the pancreas in chronic pancreatitis. If you do a frozen section, it is not reliable, even if you do a core biopsy transduodenally. So endosonographic fine needle aspiration, fine needle biopsy is probably the way forward if there is a clear-cut mass. If there is no clear-cut mass and there is a dirty head, you're not sure whether it's malignancy, you then do endoelastography. This can be color-coded endoelastography, where a blue signal indicates a hard mass, a red signal indicates a soft mass, and a green signal indicates an intermediate mass. Obviously, because of desmoplasia, carcinoma is the hardest of all the entities that are seen. The other advantage of endosonography is that it will identify microcysts in the head of the pancreas. You can also trace the pancreatic duct and the bile duct. If you see a thin tapering and a narrow tapering of the pancreatic duct, the reason is most likely to be chronic pancreatitis. If it is an abrupt closure and there is an irregular nature of the duct, then you can suspect that it could be because of malignancy. Now, just color coding is not sufficient and confusion is rife in such cases. So we do endoelastography, we do quantitative ratios of elastography of the mass versus elastography of the normal pancreatic tissue. There it has been found that you get a 1.68 ratio if you do an endosonogram in a benign lesion. In chronic pancreatitis, it goes up to 3, while in case of malignancy, it's as high as 18. So this is one way of differentiating whether you have a pancreatic head cancer. The other thing is you can do a cutoff for the you can look at whether there are microcysts visible in the head of the pancreas, which will put it more in favor of pancreatic chronic pancreatitis. The other test that you can do is an MRCP. MRCP, the advantage of MRCP is you can study the ductal structures very well. If there are ductal structures in the head of the pancreas, it's chronic pancreatitis. If there are no ductal structures and there is a mass-like lesion, which is hypointense on T1 and hyperintense on T2, you can think of malignancy. Also, there is diffusion-weighted imaging of the pancreatic head done by MRI, where the amount of fat which is present in pancreatic cancer is more than the amount of fat present in chronic pancreatitis fibrosis. So if you have more fat, it's more in favor of malignancy. Then a routine CT scan is helpful if it shows evidence of lateral spread, if it shows a deformity of the portal vein, then it's more likely to be malignancy. It also hints at the difficulty which will be found if you do these cases when you are trying to do a pancreatic duodenectomy for a suspected mass, which could be either chronic pancreatitis or malignancy. The other thing that one can do is, in these sort of situations, is to do the contrast ratio. You administer contrast, you do an arterial phase, a pancreatic phase, and a venous phase. And in the arterial phase, it is seen that in malignancies, the enhancement is not significant, but the enhancement is incremental. If the enhancement is less than 0.17 as compared to normal parenchyma, it is more in favor of malignancy. The other thing that has to be observed is that if the gradient in pancreatic tumors is that the pancreatic tumor starts accumulating contrast and the contrast increases as time goes on. While in chronic pancreatitis, it is increases and then reduces. While in case of normal pancreas, it is a washout, a rapid washout. So this is how you can differentiate the clinical picture.
So thank you very much, Dr. Desai. The message is that you should avoid a surprise on table. By and large, if you have a imaging done quite some time before, there might be many number of patients who might be having exhibition of pain and inflammatory mass over there, but few of them may be harboring malignancy. As you rightly said, that based on clinical signs and symptoms, things become very easy sometimes. Yes, based on history, there's significant loss of weight, appetite, and then the patient has jaundice, icterus, which is more commonly seen, but it is equally seen in biliopathy and edema around the duct. And you have to have investigations which should be practically available. And maybe the elastography and the enhanced endo-US may not be available to most of the centers. But a simple CT, as you said, and MRI with diffusion restriction would give you some pointers toward the masses malignant or benign. Very importantly, we did not put up any cutoff levels for CA19-9 because we have been seeing, if I would say about this lady, whom we did not operate because it looked like encasing the vessels. Actually, after adding antibiotics and doing an FNA where a lot of pus was aspirated, she had subsequently a decrease in her CA19-9 by a few hundreds and then again increase, but it looked like that she has a malignancy which is unresectable. We still did not get the biopsy, as again he said that many a time the biopsy or the frozen section may not be the right kind of an answer. You have to have an extensive evaluation of the specimen. And sometimes you might have to do it for based on the resources available. If today's era we need to have a bleed, we can do it with angioembolization and subsequently take care of pain. This patient had extensive pain due to chronic pancreatitis, and we did a 2-in-1 kind of a treatment of aneurysm as well as the chronic pancreatitis. And sometimes a chronic pancreatitis may not be harboring only mass in the head, but it may be a mass in the tail where you need to go and dissect it. But the key thing is that with all those that he has said, I will not repeat it, that you have to look into those signs where you think that there's a duct penetrating sign which is smooth or irregular in inflammatory and malignant. The side branches are more dilated in the benign, then the parenchyma ratio is grossly dilated in malignant. You have displaced calcification in the malignant. You have a double duct sign, which is a very common sign, which may or may not be very accurate. And your vessel encasement is peculiar in malignant as compared to benign. The ratio of SMA to SMB actually changes. The SMA becomes more bigger. So, having said then, endo ultrasound has to be the gold standard to take an FNA and try to look into whether it's malignant or not. Because at the end of the day, chronic pancreatitis malignancy does not have a very high benefit of survival, you can say. And the challenges while doing operating on a patient with chronic pancreatitis with pimples is very high because it's very technically demanding. There's all fibrosis around. Even a simple making of tunnel may create a lot of bleed or a vascular injury. And you have to have a highly skilled pancreatic surgeon to take care of this area. Very important message for the beginners. You are also likely to come across a lot of portal hypertension in chronic pancreatitis. So it's not a matter of opening of duct and boring a small area in the head, but it's a matter of doing an extensive surgery where you have to mobilize so many things. So these are the problems. You have to be well versed with taking care of bleed from the congested vessels if there's additional subclinical portal hypertension in these patients. And you may have a sudden bleeding while tunneling the superior mesenteric vein. But if you are properly and empirically cauterized, is as I said in the previous case, just a pinching in between and a fast division of the neck or further division of the vein under the clamp are the two options as Dr. Ajay has said before. And of course, we repair the vein with very fine sutures with very watertight kind of thing. Now going to another.
Move to the next. Can I just two or things important. For all the beginners, take it as a rule that CA19-9 in chronic pancreatitis is not a marker of malignancy. The most common mistake.
Yeah, that's what I told them that you have to.
Whatever may be the level. Some people say that it is 1,200, so I am worried. Some people say it is 5,000, so I am worried. No. Don't take increased CA19-9. We have got a reference from a patient who was operated elsewhere undergone a PD for a CA19-9 21,000 and biopsy was negative. So that has actually after that we have read it a lot and we have realized that CA19-9 is not a marker and saying it so emphatically to you. Second thing, it has been very well said that there are very good markers on CT, MR, but to read from a book, they all look easy. When you see it on CT scan, it becomes very difficult. It normally takes 15 years to understand what book has written and what CT is showing. So it is not easy that you differentiate on CT scan or MR. And more difficult area is when, as I said, that Desai was saying endoscopic USG, it looks easy endoscopic USG, but even the best of the people specifically in case of chronic pancreatitis with inflammatory mass in the head, it is not easy to go into the duodenum. Beyond the fibrous, the endoscope does not enter. And then to turn it, and then to fix it, and then to identify the site, and then to scan the entire inflammatory mass, it becomes very difficult. So, you have to, as Dr. Kapoor said, tells us most of the time, my residents are here, they will agree. It's the time which tells some time. In spite of your best efforts, you can't identify. It's the time which will tell.
Exactly.
Yeah. What point I'd like to emphasize is if you have confusion whether it's malignant or not malignant, treat it as malignant. Because in largest series of pancreatic duodenectomy, incidental pancreatic duodenectomy for chronic pancreatitis assumes only 5 to 6% of cases. And if you lose out on a patient who is resectable and wait, you're going to end up with a patient who's going to die on you. And he should not die just because you have not been aggressive enough to remove the head of the pancreas.
So that Dr. Murugappan also is on.
Yeah. So I have, we would have another set of patient for him. Dr. Murgan, we have another young lady who is 17 years old with severe pain. Lot of analgesics are dependent. I have those, will not go into discussion of how to decide on surgery. I ask them to keep a record, either they are referring for medical G for long treatment or we see whether they merit surgical intervention or not. But I am counseling her many a time that I will not operate on you because her duct is very small. I am a surgeon who is looking for better size duct. But then I am compelled by the patient that if I have even 50% chance of recovery, and I should operate on the patient. But you go into and operate upon the patient, this is again an intraoperative issue. You start sweating for at least half an hour, 45 minutes, and you prick here, you prick there, and you are not able to enter the duct. But once you are senior, you know many more methods about how to get into the duct and what all to do. So, Dr. Murugan, if you are there, you can please elaborate on how would you take care of such patients when the duct is not formed while operating on the patient? Like
Yeah,
few of such cases are there.
Yeah, so this is the subgroup of chronic pancreatitis called the small duct chronic pancreatitis. It is variably defined. Some groups put it as duct less than 5 mm, whereas other groups call it as the duct less than 3 mm, a non-dilated pancreatic duct. The usual methods of identification of the duct, like the palpation, digital palpation, or use of a needle aspiration of the pancreatic juice, or palpating the stones, or for that matter, even a intraoperative ultrasound, which is used as an adjunct, may not help us in identifying the duct in these cases. The primary reason being the head being the pancreas being woody and indurated, and it being bulky, you're not able to locate the duct. What we have found to be successful in these cases is to forget about the duct once you have gone in with the plan of doing a fray, and I go in, get in, do a proper complete cauterization, identify the SMV, identify the portal vein, ligate the GDA either in continuity or after you have isolated it, and take these sutures along the pancreatico-duodenal arcade, so that you're clear on the tissue that has to be cored out. And so now, with the surgeon's hands, fingers being behind the head of the pancreas and the thumb on the anterior surface, one is able to palpate the thickness of the tissue in the head region. And then, as others have mentioned in the panel, to start with the coring. But one point I would like to make here is adequate preparations that need to be taken before one starts the coring. At least have 240 prolines on long needle holders ready, 1 5 core suction, the assistant being ready with the suction, and start the coring, start off with small slivers, so that you're able to control the bleeders as and when you identify them. So the bleeders can be controlled with the surgeon's
Voice is gone. Your voice is gone.
using the proline. These stitches can be taken and the bleed can be identified. So as you go with the coring, you identify the duct of the Versen, and once the duct is identified, then one can use either intubate the duct either with a.
I think we have some issue with audio, so his visuals are there. So as he has put most of the things in the right perception, for
available to do the analysis is
Yeah.
quite. It's as in a 3 mm duct, when opened up, will give us a length of around 1 cm.
आपके यहाँ आ रही है आवाज, इसमें क्यों नहीं आ रही है?
Dr. Mulkan, we cannot hear you, but we have taken the points well. You have put forward most of your points. And as he rightly said, that many a times they might not be very helpful. But sometimes you have a 4 mm, 5 mm duct also, which is not very dilated, it becomes very difficult to locate it with just palpatory method. And so you need an intraoperative ultrasound. And if you are having still smaller duct, then you can start with coring of the head of the pancreas, and sometimes somewhere down the lane, you will have an understanding where the duct goes. You can give a direct incision on a palpable stone, as you rightly said. You can incise, or you can say excise a full thickness of the duct and see from the distal area whether you can probe the duct and come retrograde and open up the system. And if the duct is small or a side branch disease and severe pain, and you've decided to operate on the patient, and patient is every second in hospital, I must have come across at least 5 to 6 such patients in a denominator of 200 plus chronic pancreatitis surgery, where we had no options other than going in and giving the chance to the patient. And I'll tell you that the Isabekis procedure actually fetches good result. The lady was so surprised that she did not have pain. I had counseled her that you have done this dependency, you are likely to come back with pain, readmissions. I could not trace her even for her imaging this time. She had a rubbery pancreas with hardly any duct being seen. I just poured out the head and gave a V incision on the rest of the parenchyma. It was a broad and a heavy lady, and you have to give the amount of V incision based on the size of your patient, and just give an on-lay pancreaticogynostomy in these patients. You do come across such cases, and these are the ways of we handle small duct disease. If some of the panelists want to add some more points regarding small duct disease, we can add and then take questions from other audiences.
The SVK's procedure is not available. Is actually defined for a very unlimited duct line onto the pancreas. What now? What you're telling is a much more difficult area where you don't have a duct. You don't have a duct, you can't see the duct, which is less than 3 millimeter size. So in that case, it will not come under the definition of SBK, but it is just scoring of the pancreas. You expect the second order ducts to drawn into the opening that you have made. So that is actually to decompose the pancreas and it relieves the pain. What you said is very correct that this has a equal or even a better result in pain relief, especially in the patients in which you have a dilated duct. Because in this group of patients, it is not the intraductal pressure that is the cause of the pain. Rather, it is the inflammation in the entire pancreas that is the cause of pain, which is as in other chronic pancreatitis, the inflammation in the head of the pancreas that is the most major source of pain, which is indicated by protein. But all the storing of the body and tail. I think
it's like that. I mean, to make it a point that you don't give all trans thickness suture. Your anastomosis should restrict to the capsule only with limited ischemic add-on effects.
audience survey which is yeah.
Yeah, Dr. Pradeep, would you like to add a point on small duct disease, sir? Because the online
Yeah,
audio.
yeah, I think small duct disease, most of the surgeons are hesitant to operate and they try to push medical management, and endoscopist also is not interested in small duct disease. Those are the cases which they actually ask the surgeon to handle it. So I know it's a very difficult problem to handle, but still I think you can still get a decent amount of results if you do proper drainage of the system, where you might not get the duct anastomosis, you might have to attach to the capsule itself. But the biggest challenge would be identifying the duct. Now with the use of intraoperative ultrasound, or you can just start, the gland is slightly bigger, you can just core out and you can get in the head region, and then retrogradely you can get into the duct and then anastomosis. But the problem would be you can't do mucosa to mucosa anastomosis in many situations. You take in a capsule and that is sufficient to, and you do get a decent amount of long-term results, though it is inferior to compared to a large duct disease.
With Dr. Pradeep making a very valuable point. Can we have some questions from the audiences? Somebody wants to make a comment? Nothing is easy. Those who are doing it, no.
So the section is difficult in CP, but anastomosis is easy and results are better. It is non-secreting, but it doesn't leak.
It does.
But you have to modify your technique of making the region. You have to lay open the whole of the duct and make an anastomosis. It's not just on the stump of the.
Now, but you have some references for that?
Yeah. I have
because I have done quite a few CA head of pancreas with chronic pancreatitis, and it's like a tube over there. Anastomose, I have anastomose it with L2. I don't know whether
inside.
Yes, stasis over there. Stasis over there may be a possibility.
I think both of you are on the correct platform. Only thing is that the point is different. If you have multiple stones in the region of body and tail, you have to lay it open for the entire gland. What you said is patient is having a dilated duct and not having it is having only obstruction in the head of pancreas. Simple PD will do as we do at normal anastomosis. Dr. Kapoor, questions like that. Oh, that's time is over.
Desai is one of the senior most surgeons of the country, and he told me that he's still very active, and he was to be in Jaipur for some, I think, social or family, but he saw the program and he said, I must attend. Thank you very much. He wants to do.
I know Dr. Kapoor for last almost more than 40 years. No? SCPG, I met him at SCPG almost 40 years back, and since then we are friends. I would like to ask you that in chronic pancreatitis, in spite of doing all this, sometimes the pain does not go away. So do you do any additional procedure like sympathectomy or excision of the, the lymph nodes there around the pancreas to take care of the pain,
No,
which is not getting relieved?
like you want to say that pancreatic flap denervation kind of thing, we don't
Yes.
add it intraoperatively, but quite a few patients may come back. And if they come back with 1 or 2 episodes in a year, it's okay. We admit them and give a routine protocol of IV fluids. But those who have persistent pain or failure to respond, we try to tie it up with celiac clock. A celiac clock, it gives us some time buying for 6 months or 8 months. And many times they do settle them. They do settle with 1 or 2. But if the pain is very chronic and debilitating, then the next step would be, as you said, that you can do a total pancreatectomy, and all those options are there. But I personally don't believe in redoing the procedures unless I pick up a malignancy in my follow-up case of Graves or a follow-up case of LPJ, where I think that I can possibly resect it. And I have done few cases resection.
I totally agree with you, but recently I read that small dose of irradiation also helped in relieving the pain of pancreatitis.
Yeah, maybe, but we are not using it as of now. We are using it celiac access block.
Able to quote that article.
In fact, a total pancreatectomy can be an answer even
Yeah,
for that disease. We did not
answer,
discuss
yes.
it previously, as well as for those who have recurrent.
Now slowly this total pancreatectomy, autodigestion
coming
and
back
the
again.
islet implantation is slowly increasing. I think
Coming
Dr.
back again.
Pradeep will be able to tell us. His group is doing that.
Yeah, and Jaipur group is doing a lot of total pancreatectomy. They are showing good results.
Yeah. So I think the problem with chronic pancreatitis going for a total pancreatectomy is the amount of islet cell yield will be much less. That's a challenge in. So if you want to do total pancreatectomy and get islets for patient to become euglycemic, you really require 3 normal pancreas. So only then the islet value will be that much. So that is a challenge, but we have done few about 12 patients where autotransplantation was done, where the patients required insulin, but probably the smaller dose of insulin. Those patients where we have done a distal pancreatectomy, those were the cases where we have selected and found. The challenge we faced was the amount of islets we get in a fibrosed pancreas is much smaller and actually a normal pancreas. That's a challenge we faced.
Correct, rightly put it over there. Those who are not diabetic, then you can have smaller doses. Those are already diabetic and already on higher doses. So you have to weigh your patients for chronic pancreatitis, total pancreatectomy. But there is an upcoming trend of using total pancreatectomy more frequently with the present era of very good endocrinology support, and it can take care of recurrent pain. But as of now, I haven't read any article where you add a procedure while operating that you don't take care of the pain not coming back again. And those, if you take hardcore recurrent pain, that subset of patient 200 would be only 5 or 6 or maximum 8, not beyond that.
The other thing I would like to see is when a patient already had an LPJ or pancreatic genostomy, if he comes back with pain, we should first evaluate properly because the pain might not be related to the pancreatic origins, which we have seen in a couple of patients. The second is you have to evaluate whether the drainage is adequate or not, because sometimes the drainage might be incomplete, only they might not have drained adequately the head. So we had few patients where we have redone the procedure and then we completely drained, poured out the head. So these are some of things we should not forget rather than condemning a patient that it's a failure of surgery, particularly when you are not involved in the first surgery and you do not know what the surgery was done.
I've encountered the patients who have been waiting for the surgery, but in between they come back with observations. And then when you do amylase lipase is very high. So now in that case, would you proceed with the drainage procedures or you wait again?
That should not be done. You have to wait until the inflammation comes down. I've had a situation where one of our colleagues proceeded and did a phase procedure. And then he went into pancreatic necrosis in the post-operative period. Luckily, we had tubes in place. We just started irrigating the tubes like a Bajaj procedure. And the whole pancreatic cast came out one day from the wound and the patient settled down. But don't expect such good things to happen.
How long do you wait?
3 to 4 weeks. And give octreotide to prevent any further episodes of inflammation.
And re-evaluate with the CT also.
Yeah,
Yeah.
if you have re-evaluated CT and if you have that kind of situation, you have to do the procedure very well.
Amylase lipase with inflammation in the hypopancreas. Repeat. Increase amylase lipase, pancreas appears to be normal. Just wait for a shorter time, reevaluate. The pancreas still normal, go ahead with surgery. So it depends upon CT scan. Basically, upon the investigation, what does it show? If it shows inflammation, you have to wait anyhow.
Thank you.
Thank you.